Hi everyone, welcome. Today we got a great presentation. We're going to have case discussion series, and today we're going to have a great case, right? So let's start.
Yes. There was a 51-year-old male
Mm-hmm.
who presented with right lower quadrant abdominal pain 4 days ago.
Let's stop right here. Right lower quadrant abdominal pain, right?
Right.
So the first question I always ask when a patient comes with the abdominal pain or anything patient comes in, what is the emergency I could miss and have complications, in immediate complication patient can result, okay? So what is the term we use? Anybody know? Or what is the emergencies? What is the abdominal emergencies I could miss out? Serious complication, patient could die. What are the emergencies?
Any abscess or
Any
something?
abscess? It doesn't, you can have an abscess, but it isn't going to kill the patient right away. Okay, so what killed the patient? There's a term called surgical abdomen. Okay, always your first job when somebody with an ER doctor call you and said, I got a patient come with abdominal pain. Is it a surgical abdomen? Okay, so what are the surgical abdomen? Let's say if you have esophageal perforation, peptic ulcer disease, right? You get a perforation, any kind of rupture, abdominal aortic aneurysm rupture is also very common. You have the abdominal aortic, that patient will be dead in 30-40 minutes, right? You need to call the surgery right away. You don't have the time to do your regular assessment and plan and all that. So very, very important, right? Any kind of mesenteric ischemia, the other one, right? When you have a bowel infarction, what happened? You got patient is pain out of proportion to the presentation, right? Those kind of things, patient will be dead. So remember, any kind of perforation, esophageal perforation, especially peptic ulcer perforation, abdominal rupture, mesenteric ischemia, those are the huge, huge emergencies you cannot miss. All right, when you talk about the right lower quadrant pain, right? Let's talk about a little bit about our differential diagnosis. Usually what I do is I have this mnemonic, I've seen it called appendicitis, okay? So we'll write appendicitis. Okay, and I have to tell me what is the mnemonic of course everybody know appendicitis, right? So when we talk about appendicitis a little bit first. The best tool to diagnose appendicitis is called what? Alvarado's tool, okay? You got some numbers, you got a mnemonic also called a Mantrail score. Okay, so what do you do if you wanted to rule out, always use some kind of tool like a risk assessment to rule it out, okay? So what is Mantrail? So it's good to know Mantrail, M-A-N-T-R-E-L-S, okay? M is migration of the pain, right? Migration. A is patient usually have anorexia, right? N is nausea, vomiting. T is the tenderness, right lower quadrant tenderness. R is rebound tenderness they can have, right? E is elevation of the temperature, and L is leukocytosis, and S is the shift, maybe a left shift. Okay, this is kind of because, remember we always talk about find out the likelihood ratio. When the patient have positive likelihood ratio of the symptoms, your odds of your diagnosis extremely higher. So when you use the Alvarado's rule and come with the Mantrail's mnemonic, and if it is greater than 7 points you get, each one have 1 point, and if you get greater than 7 points, your likelihood ratio is 3 to 4. That means your odds of diagnosis is gonna go to maybe 25 to 30% higher. Okay, so we talk about appendicitis. Let's go to the mnemonic appendicitis. What is P? Somebody tell me.
Psoas abscess.
Okay, it could be psoas abscess. What else? That's fine. Other P? Pelvic inflammatory disease, right? PID. A lot of female kind of issues right there. E, what is E?
Endometriosis.
Endometriosis. Okay, and neoplasm, right? Any kind of colon cancer or those kind of things. Carcinoid also, very common. You got the neoplasm. D, diverticulitis, okay? Main diverticulitis on the right side, you have to work on Merkel's diverticulitis is very common in children, right? And then you have what? Cecal diverticulitis, very common. And what is the I?
Intussusception.
Intussusception, got it, okay. Valvulus and those kind of comes into contact. And then C? Crohn's disease, and the cyst, kind of ovarian cyst, right? And I could be inflammatory bowel disease, right?
Yes.
Again, and then T, torsion, right? You
Yeah.
can have the torsion of the ovary, torsion of the testes, and all of this can happen. I,
IBS.
in irritable bowel
Right.
syndrome, right? Is I mean, most people, it's very high irritable bowel syndrome. And S,
Any stones? Kidney
stones. What type of stones?
Renal
Renal.
kidney
Renal stones, okay? So this is a good kind of, I mean, remember this mnemonic, like anytime the right lower quadrant pain, the first thing comes to you like appendicitis, okay? When you talk about appendicitis, think about Alvarado's rule and the mnemonic, Mantrel mnemonic, and come with the score, and then rule out is not appendicitis, okay? And then you look at the other differential diagnosis and go there. So tell me a little bit about this. So we know, what is the, you said right lower quadrant abdominal pain, tell me a little bit about it.
Yes, so the pain, it was gradual in onset, it was
Uh-huh.
sharp and aching in
Okay.
character,
Uh-huh.
and was intermittent, and it was 7 out of 10 in intensity.
Okay.
And the pain,
So 4 days pain in,
Yes.
and then with sharp.
sharp and
Okay,
aching.
okay.
Intensity was 7 out
Yeah.
of 10. The pain is aggravated with changes in position
Okay.
from standing to laying down and vice versa.
Okay, what kind of pain, like, and really, when you aggravate, like, what other type of pain can go up when you move? Definitely peritonitis,
Peritonitis,
right?
Right.
And then kidney stones also, like,
Yes.
very painful kind of pain, those kind of things. What is the pain about the kidney stone? Where do they usually radiate to? To the groin,
Yes.
testicles, and those kind of things also very, very important, okay?
Correct.
And what else? What else the other in the
Yeah,
presentation?
and in January, he had the subsequent, colostomy reversal done.
So he had a surgery done.
Yes.
Okay, so what happens when you do surgeries and all that? You can have like complications, right? And
Right.
it's up to after surgery, they can have an abscess and those kind of things
Ridiculous.
also. All right, let's come to the past medical history.
Yes, past medical history, colostomy was done.
Mhm.
That he had diverticulitis.
So why was, anytime somebody said, don't tell me the colostomy, right?
Right.
What was the reason for the colostomy we need to know? Is it like a malignancy? That's the main thing we need to
Right.
rule out. Or something else? Why did they do the colostomy?
He had perforated diverticulitis.
Perforated diverticulitis, okay? So that's very probably the colostomy. What else? What are the other history?
He has hypertension. He
Okay.
had an MVA motor vehicle accident.
Okay,
And past surgical history
okay.
would be, he had abdominal surgery done.
Mhm.
He had ankle surgery, colon surgery.
Yeah.
Uh,
Okay, so you got a lot of abdominal surgeries.
Yes.
Why should we be worried about when you have somebody with a lot of abdominal surgery?
Additions.
Adhesions, right? Very painful, those people and all that too. So those kind of things also very common, especially if people have a lot of surgery. Okay, now what is that like? Now when we did the past medical history, allergies, what are the allergies?
He had allergies for benzoyl peroxide,
Okay.
hydroquinidine, nickel, and platinum.
Okay, so we did the allergies. Now tell me you can go, let's say the family history.
Right. There's no significant family history. with this
Okay, is
patient.
it anything kind of important in this? Right lower quadrant pain could be?
No.
I mean, why not? Could be a malignancy, right? But usually like why would have like something doesn't say, 4 days duration, those kind of things. It's not very common, but it's good to know like any kind of history of the malignancy in the patient's family, right?
Right.
All right, now after family history, like tell me the medication, what the patient is on.
Right. He's been taking oxycodone.
Yeah.
He's taking Percocet.
So we need to know, like, I know this patient is taking pain medication,
Right,
right? So it's
right.
kind of telling me, like, he's been having like some chronic pain, okay?
Right.
What else the
He's
medication?
taking Percocet.
Mhm.
He's on fish oil, multivitamins.
Yeah.
He's taking Zyrtec and Lutensin.
Okay. All right, so we talk about the medication, we talk about family history. Tell me about the social history.
Yes. On social history, he is single and not married.
Okay,
And
is that it? Do we need to know about the smoking history?
oh yes.
Okay, do we need to know about the alcohol history? Right?
Yes.
All this kind of
Yes.
like kind of related abdominal, like, so it's
Right.
very important to get a very thorough history,
Right,
okay?
right.
When you do take a history and physical, make sure you spend your time, everything systematic. Okay, tell me about the sexual history.
Um,
You have not taken
yeah.
it? Okay, is it important sexual history? Of course,
yes,
right?
yes.
I mean, a lot of things kind of sexually transmitted disease goes abdominal pain, right?
Right.
Depends upon, I mean, you have to know like how many sexual partners here, like,
Right.
those kind of things very important to have like a diagnosis, right? So what else? Psychiatric history is important. But it's still like when you do an
Yes.
HMB, do
Right.
very thorough HMB, okay? Don't take shortcuts. Okay, so we did the history presentation. Only thing we know, this patient have pain for like to summarize, 4 days of pain, and the patient had like previous history of surgery, right?
Right.
Like 2 months ago, 3 months ago, he had like surgery done. And we did not identify any red flags on this patient, kind of like any kind of thing like a surgical abdomen yet. Okay,
Right.
like, so what are we in the exam? Tell me about the vital signs. What are the vital signs?
Vital signs were his blood pressure was 146/87.
Yeah,
He was febrile.
yeah,
Pulse was 87.
mm-hmm,
Respiratory rate was 16.
yeah.
SpO2 was 97%.
Okay, so we got like normal vital signs, right? So we
Right.
just kind of say like maybe, so we have to, when you have like hypotension, we have to worry again, you know, sort of like
Right.
abdominal aortic aneurysm rupture, those kind of things we have to really worry about it, right?
Right.
So what are we examining in this patient? Tell me, what could be the examination? What are we looking, somebody with abdominal pain, what are we what kind of things we should look for? Of course, we look at the patient
Yeah,
first,
yeah.
right? Is he in severe abdominal pain?
Right.
Just, think there is some kind of emergencies kind of going on, like, surgical abdomen, right? Okay, what else you do?
We just basically do our head and neck,
Okay.
cardio.
So the
vascular
lymph node,
vascular.
always kind of think about,
Right.
the left-sided node kind of drain to the stomach, and the supranuclear, any kind of lymph node is very, very important, any growing lymph node, and those kind of things are important, right? So let's go to the abdominal exam, right? Just go to the abdominal exam. What are you looking for in the abdomen? Any kind of mass, right? Any abdominal area, like pulsating mass, so that's also we need to see. Any kind of rebound tenderness, right?
Any
Gliding
discoloration.
is kind of, those kind of things give you like a very clue. You need to know about the bowel sound. So how was the abdominal examination?
There was just abdominal tenderness in the right lower quadrant.
Okay,
And there was
right
no
lower.
guarding.
Okay, so there's no like any red
No.
flags about it in the abdominal. So
No.
what else? So you did the abdominal. So
Yes.
what are the other part of the abdominal examination we're missing in this patient?
Uh,
What's missing? Do we need to do a rectal examination?
Yes.
Is it part of
Yes.
it? Of course, always try to do a rectal examination, okay? You never know like what's going to happen, like you know, is there a bleeding kind of going on? So anytime somebody with abdominal pain is very, very important. I see a lot of people kind of missing, don't miss it, okay? How do you do a rectal examination? Just say like, don't say, when I ask you about rectal examination, don't say, oh, hemocultus negative. I need to know everything. First, I look at the rectum. Is there anything, any masses outside, any fissures, any bleeding kind of going on, right? And then I look at the rectal tone. I look at it, right? And then I look at the vault. So what's going on? Is there a mass? And then finally, I come to what? Is there a stool? Like, is it blood in there? Like, and then I kind of describe it. I even describe the smell of the stool, and those kind of things kind of very important. So do it like very systematically, right? So we did that, and what are the labs? What labs are important to us? Let's look at the first, let's do the labs. What is important to us, and why is it important to me? You have to tell me. What are the labs important? CBC is important to
CBC.
you? Why? What do we need to know? Why is WBC important?
infection.
Infection. What is the WBC in this patient?
8.9.
8.9. Okay. Hemoglobin?
Was 11.9.
Okay.
Platelets was 377.
Platelet, what is a platelet is what?
377.
377.
Yeah.
Okay, so what we need to know, like, we need to know there's an infection, there's a leukocytosis, we need to know there's any bantemia, we need to know like left shit, we don't have any of this. We also know like we know a little bit of anemia, right? Hemoglobin. So we also need to be worrying about that. Why is it? Maybe some bleeding. It could be like, a lot of blood loss and all that. Too. Platelet is an inflammatory kind of thing. You can kind of, what are the markers of inflammation? Somebody can tell me?
ESR, CRP.
CRP.
ESR, CRP, everybody know that, right? Which inflammatory marker goes down? All the inflammatory markers are like goes up. Somebody tell me, which one?
Albumin.
Albumin, very good, excellent, great answer, okay? So albumin is the only inflammatory marker which kind of goes down. So now let's go to this thing. Sodium is important, right?
Yes.
Why sodium is important? Patient could be like, anytime somebody has low sodium, that's a bad prognostic marker, first of all, right? He may be like a depleted, volume depletion, those kind of things could happen, right? And then what else? What is this I'm looking for? Bicarbonate. Why is bicarbonate important in this patient?
To check for acidosis.
Acidosis, metabolic acidosis, right? Anion gap metabolic acidosis is very, very common in these people. When you have abdominal emergency, when you have like what is a non-bicarbonate? That's like 24. If it is like if it is less than 20, I will seriously kind of worry about it, okay? And then we need to know about the renal function. All of these are normal, I assume, right? Is it
Yes.
normal?
Everything is
Renal
normal.
function, why is the renal function is important? High BUN, okay, that can also cause abdominal pain.
Right.
renal failure, right? Then you have to worry about anytime abdominal is like a kidney stone that could cause obstruction or anything. A malignancy can obstruction, renal failure can go up. All of this, what are the labs you need to know, right? ESR is important, CRP is important. What else, guys? Come on. Lactic
Okay.
acid is important?
Yes.
Of course. What is the lactic acid in this patient? Did we check? Nope. You got a minus point for that, my friend. So lactic acid should be checked. Any patient with an abdominal pain is very, very important, okay? And then what else? Liver function test, is it
Liver
important to
function,
you?
yes.
Okay, that's very good. Like this stuff, what the LFTs were normal? What is the abnormal in the liver function test?
Alkaline phosphatase.
Okay,
It
so
is-
increase alkaline
Phosphatase,
phosphatase.
yes.
Okay, we'll come back to that. Increase alkaline phosphatase and all the other, so only thing we just found is like everything is normal, only alkaline phosphatase is abnormal, right?
Right.
Any other labs in the right lower quadrant? Do we need a urine analysis? Why is nobody talking about urine analysis?
Yes.
Of course, right?
Yes.
So what is the urine analysis? What are we looking for in urine analysis? What are we looking for? Urine WBC, right? If it is greater than 5, UTI. Okay, most important for UTI is urine WBC is greater than 9. Then also hematuria. If it's like hematuria, what do I need? Why should I worry about hematuria? Why is it hematuria? I should be worried. A 51-year-old, right? How old is this patient?
51.
Kidney stone, can it
Right.
cause hematuria? Okay, what else hematuria kind of like I should be concerned about? Is somebody with hematuria. What is hematuria? It's like microscopic hematuria. If it's greater than 2 RBCs in the urine, then you have to think about microscopic hematuria, okay? So that need to be like addressed. Why is that? Number 4 cancer in the United States, what is that? Bladder cancer. Okay, so you have to like, so anytime somebody, if you're an outpatient basis and if you see a patient with hematuria, be careful. Bladder cancer is rating very high. Okay, the board question I'm going to give you, like a board question about bladder cancer is what? How do you treat bladder cancer, superficial bladder cancer? What is the unique treatment? Come on, BCG vaccine. Okay, board is
Okay.
going to ask you. Got anti-inflammatory properties. Studies have shown after the resection, if you give BCG doses and kind of put it into the bladder, the recurrence rate is around less than 80%. Just another, not related to this case, but just a clinical point we need to know. All right, what are the next thing you have to do? What is the next imaging study? What do you have to do? What's the next thing to do in the emergency room? You go for ultrasound? How long is it going to take the ultrasound?
Sure.
How long? 3 hours,
Yeah,
4 hours? Have you ever ordered it?
No.
Sometimes they come back the next day, the patient will be dead. So what's the first thing you should do? What is the easiest thing to do, get the
X-ray.
results? Huh?
X-ray
X-ray,
exam.
abdominal X-ray,
Right.
boom, you can get the results right away. By the time you go to the ER, the results are there. Always make sure, look at it, surgical abdomen perforation, right? And then you talk about, what did they do in abdominal X-ray? No, they did not. Okay, so what are the other imaging tests they did? What are the other imaging tests?
CT.
All right, tell me the CT scan finding.
There was mild wall thickening of the lower rectus muscle.
Lower rectus muscle wall thickening,
Right.
right?
And there was also mild wall thickening of the gallbladder.
So there's a gallbladder thickening,
Right.
okay? What else?
And CBD was 7 millimeters.
Okay, what else?
That's all that we.
Okay, all right. So just talk about this thing a little bit. CT scan finding. So we know lower rectus muscle is kind of located. There's some thickening, maybe some kind of inflammation. Could that cause pain in this patient? Right?
Yes.
Very possible,
Right.
right? You had like previous surgery done, and then maybe like something has to do, some inflammation kind of thing, but there's no leukocytosis, and very unlikely to have but you should have checked lactic acid, but we did not see any metabolic acidosis or good sign. Now talk about the gallbladder, very, very important. Why is the gallbladder wall thickening is important? What's your diagnosis? When somebody with abdominal pain, gallbladder wall thickening, well, first of all, what's the normal size of the gallbladder wall? 4 millimeter, okay? If it is more than 4, kind of think about cholecystitis. Gallbladder wall thickening, the gallbladder wall is greater than 4 millimeter, pericholecystic fluid, gallbladder wall thickening, then you kind of think about this cholecystitis going on, right? The next thing you need to know about common bile duct. He said already 7 millimeters. So what's the normal size of common bile duct? You have to know, like what's the number? 6 millimeters.
Six.
Some numbers you need to know, because if you know that, it will help you. If it is greater than 6, that means there's a common bile duct dilatation. Why is it important? There may be a stone underneath it, right? That's the most common reason. So we know common bile duct is increased to 7 millimeter, right? Anything, we just got to think about it. Now, what situation, the question you can ask, can you have gallstones after cholecystectomy? You can still have it, okay? Don't make the mistake. And near the stump, you can have the stone formation, okay? So when a patient comes with a common bile duct, I look at the patient, right? Let's say a different patient. A patient come in, had a common bile duct, say like, hey, I got 12 millimeter or common bile duct. What's the first thing I should ask myself? Anybody?
Surgical history.
Yeah, why is that? First you want to know, did they have taken the gallbladder out? Okay, there's something called a post-cholecystectomy dilatation. Okay, after the cholecystectomy, common bile duct dilated. That's kind of normal. So don't jump into any kind of conclusion. Okay. There's also something called senile dilatation. It's to say if you have a grandmother, it's like 85-year-old. They come with the common bile duct is around like 9 millimeter. Then you just kind of say, hey, maybe this could be like senile dilatation. Okay. Those are these things. But remember, you need to know what are the signs of cholecystitis. What are they? Just repeat. Gallbladder wall thickness. How many millimeter?
More than
4 millimeter, right? Pericholocystic fluid, pretty much you can say this patient actually cholecystitis. Common bile duct, what's the normal size of common bile duct? 6 millimeter, okay? And what's the first question you ask if the common bile duct is elevated? Past history of cholecystectomy. And if it is still elevated, if there's no cholecystectomy done, then you kind of think about all the other kind of thing, okay? And think about senile dilatation of common bile duct also. So we got a lot of lab results up here. Let's go to our assessment and plan and finish up the case for today. So tell me, how do I write an assessment and plan on this patient, my friends? Right, very, very important, right? What is the number one issue right here? Right lower quadrant abdominal pain, right? What do you think? We have CT scan kind of supporting some rectus muscle wall thickening right here. No other signs of infection, right? Thickening. You had previous surgery. Maybe it's a good idea to ask the surgeons to comment on this, see something else kind of going on, we're missing, right? It'd be a good idea to discuss always. When I have finding like this, I'm not so sure what's the first thing I do. I go to the radiologist room and say like, hey, just kind of tell them like what's going on. And this is the situation with the patient. They don't know the clinical history and what am I looking for and all those kind of things. I did not find any abscess or any of those, no renal stones or any of this, right? So, and your supportive care you can do, pain control, right? And those kind of things and all that too should be as important, right? What are the other issue in here? What else? Elevated alkaline phosphatase. All right, let's talk about like what are the common places alkaline phosphatase can come from? 3 places mainly. What is it?
Bone and
Liver, biliary structure. What is the other one? Bone.
Bones.
Okay, what is the other people usually miss? Female. Give you a clue.
Okay.
Placenta. Okay, very good. So only 3 places you can pretty much find the alkaline phosphatase, right? So what's the first thing you do? So we need to know liver, gallbladder, right? We need to know bone. We need to know his placenta, right? Easiest thing to do, ask the patient if they're pregnant or pregnancy test to make sure, right?
Yes.
That's easy. Like, this is a male, 51-year-old cannot be pregnant at this point. So we just kind of like, all right, bone, and how do you differentiate? What is the test you have to do next?
GGT.
GGT, very good. So you do GGT. If it is high, you will say what?
Gallbladder, liver.
Okay, gallbladder, liver disease and all that. Did they do GGT in this patient?
No, sir.
Okay, so we have to do, first thing I would do rather than do a million tests and all that. So I do GGT, then I know common bile duct is like 7 millimeter or something kind of related to that because it was also, I will write it down, check GGT, right? And then based on that, then I proceed. Maybe I need to call like ERCP to look at it or do an MRCP, those kind of things, very important, okay? So this is the way I like to do my assessment plan. Any other questions for today? Okay, thanks.